Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm serving clients in the healthcare industry nationwide.
Today, on Diagnosing Healthcare, we will discuss the PACE program, a specialty managed care program that serves frail elderly patients who need long-term care services but would like to continue living at home and primarily caters to the dually eligible population. Those are the people covered under both our Medicare and Medicaid programs. As this is particularly timely with a pending federal proposed rule that makes meaningful changes to the operational requirements of this PACE program. Hello and welcome. I'm your host, Lynn Shapiro Snyder. I'm one of the managing partners at EBG, where I practice law for over 40 years. My experience includes advising on Medicare, Medicaid, commercial payers, and other types of health regulatory inquiries. While many people know about the more traditional Medicare Advantage programs covering Medicare Parts A, B, and D, less is known about the PACE program, a program that addresses the specific and particularly challenging needs of the frail elderly population, those dual eligible Medicare and Medicaid programs. The PACE program covers all Medicare and Medicaid covered services, including the long-term service and supports, as well as other services. While the capitated payments from CMS under the PACE program are some of the highest of any program in healthcare, the medical, social, and programmatic complications of the model are also uniquely challenging. While the PACE program was historically restricted to only nonprofit organizations, recent legislative changes have given for-profit companies the opportunity to offer a PACE program in states that elect to participate in the program. This is a timely topic, as I said, because in December 2022, CMS issued a proposed rule to revise regulations applicable to all types of MA plans, and they had some significant changes governing the PACE plans. The publication date was December 27, 2022, and the comments period is open right now. You still have until February 13th, 2023 to get your comments in. The specific pages, for those of you who are ready to write this down, are 79635 to 79673. We urge anyone interested in PACE to review these pages and consider filing comments, particularly in those areas where CMS specifically asked for public comment, because it is very challenging to write these proposed rules. On today's show, we're going to explore what is the PACE program generally, and more specifically, we're going to discuss these changes in recent years that have made PACE available to the for-profit companies, and we're going to explore some of the provisions in the new proposed rule. If you like what you hear today, please subscribe to our show. Diagnosing Healthcare is available wherever you get your podcasts. Okay, who are my guests today? Joining me in our discussion today first is Wendy Edwards, Director of Internal Operations at BluePeak Advisors, a wonderful consulting firm that we have worked with on many occasions. Wendy is a seasoned healthcare executive with over 20 years of experience working in commercial, Medicare, Medicaid, and self-funded insurance arenas. Wendy, say hello.
Hello, and thank you for having me on this episode. I really look forward to our discussion on this trending topic.
Wendy, thank you for being here. Also joining us today is one of my EBG colleagues, Kevin Malone, who represents both the nonprofit and for-profit PACE operators, entities in the process of establishing a new PACE program, as well as helping investors in the PACE space. Prior to entering private practice, Kevin worked at CMS in that area of the dual eligible policy issues, including the demonstration models related to the PACE model. Kevin also participated in the passage of that federal legislation that authorized for-profit PACE programs. Hi, Kevin.
Hi, Lynn. Thanks so much. It's great to be here.
Thank you. And then finally joining us is Helaine Fingold, another wonderful member from EBG who represents Medicare and Medicaid managed care entities, including the dual eligible special needs plans, PACE programs, providers, and all the vendors who support these MA activities. Helaine spent approximately 15 years with CMS working on managed care in not only Medicare and Medicaid, but also in the exchanges, and has served as general counsel of the Medicare Payment Advisory Commission. Hello, Helaine.
Hi, Lynn. Nice to be here.
Well, Helaine, guess what? I'm going to start with you. Can you give the audience a brief overview? How does the PACE program work?
Thanks, Lynn. So as you started with in the introduction, the PACE program is a three-way partnership. It's CMS, it's the state, and it's the PACE provider. The CMS and the state and the provider, they work together to serve the frail elderly participants, help them meet their healthcare needs in the community instead of needing for them to go into a nursing home. And as you indicated, most of the participants are dually eligible. The plan is paid a per member per month amount to cover and deliver all of the Medicare and Medicaid services and anything else that the care team determines is necessary to improve and maintain the health of the enrollees. Another thing is unique to PACE is that PACE is not just the plan, PACE is the provider of the services. So it's serving kind of this dual role.
Kevin, what's so special or unique about the PACE program as the managed care plan, and what have been some of the more recent innovations to provide for-profit companies with the opportunity to be a PACE program sponsor?
Sure. Thanks, Lynn. So building on what Helaine's saying, there's a lot of very unique things about PACE. It really is designed to give maximal flexibility to a primary care interdisciplinary team for managing all of the needs, including long-term care needs for a participant in the program. And because the PACE organization serves in multiple ways for all of its participants, it is a managed care plan. It's an insurance plan that has full responsibility for all claims from prescription drugs to emergency services, all the way down to home health and personal care services. It also is a primary care practice with a social adult day center, physical therapy location, and transportation provider. And because it operates both as a primary care practice, a social adult day community center, and a health plan, it really serves a unique role among all of the different managed care and primary care programs in the country. It's got the maximal flexibility and maximal resources to deliver the services that participants need. Related to that is the interdisciplinary planning process that we're going to be talking about a lot on the podcast today, which is that the PACE organizations are mandated to deliver any service that the clinical team, led by the physician, determine to be necessary. So they're not bound by a ceiling of what Medicare or Medicaid would otherwise cover, as you would see in a Medicare Advantage plan. They have maximal flexibility to arrange for and procure and deliver whatever services a participant needs, whether that's a vacuum cleaner for their to help reduce and control their asthma, to an air conditioning unit to help them stay safely in their home in a hot season of the summer. That sort of flexibility really is unique. And however, it's also extremely expensive to develop. And so the reason that when we were at CMS and we worked on the PACE Innovation Act, that we wanted to allow for for-profit entities was because of how passionate and excited we were about the model as being one of the best, most integrated models of care for people who need both long-term care services and very intensive primary and specialty care. Because you have to have a bricks and mortar facility, you have to meet solvency requirements similar to a health plan. The actual capital expenses of building a new PACE center and serving PACE participants are extremely high, and sometimes can take 2 or 3 years from beginning of the application process until you're able to open your doors and provide service. And the biggest barrier that we heard from nonprofits was that raising enough capital as a nonprofit entity to develop and expand PACE was prohibitive. And so the biggest thing about for-profit PACE authorization was to try to expand access to a model that everyone feels is the best. That's really the most exciting part about it, is to try to find ways of expanding access to PACE to people who need it, who could really benefit from it. And that's an exciting thing that we're dealing with right now in the country, is that possibility is now a reality.
Thank you, Kevin. I call it a customized benefits package. That's my way of describing the flexibility. And then also, if there's no money, no mission. You need capital in the healthcare system, and the nonprofit status alone may not always provide the necessary access to capital that's needed to grow. So let's move on to Wendy. As a consultant, I know a lot of organizations use you to get started and do feasibility and applications. What are you seeing in the marketplace? Is there an increased interest in the PACE program? Is it growing?
Yeah, it absolutely is growing. And I think the PACE program popularity has been growing so fast in part due to the success that the programs were proved during the COVID public health emergency.
Yeah, Wendy, this from my perspective, I think it's well documented from like the NPA and from other sources that the mortality figures and even the infection rates among PACE participants were way lower than comparably frail people in nursing facilities, or even comparably frail people not in PACE. It just was very effective in getting people tested, getting people vaccinated, and certainly keeping people out of high risk clinical environments because of the sort of ability for home visiting of primary care doctors. Like, it just really showed the benefits of the flexibility of the model.
Are the states different in their approach to the regulation of the PACE program? After all, Helaine said it's a three-way partnership. Kevin, do you have some comments about how does it work differently at the state level?
Sure. Yeah, because as Helaine mentioned, it is a three-way contract, and each state has to elect to decide whether or not to allow PACE in its jurisdiction, because the state pays for the Medicaid portion of the premium. The regulatory obligations for getting into and operating a PACE plan vary a lot by state. And some states like that are quite difficult to get into, like New York or California, require multiple layers of concurrent regulatory oversight for a PACE organization to participate. That includes being a licensed MCO, having effectively a clinic license for the bricks and mortar facility, in some cases also a home health license for the organization. Other states are a little more flexible with regards to the way they approach it. They just have oversight by the Medicaid agency or Medicaid managed care agency in concurrence with CMS, and don't require separate insurance license and primary care clinic license and home health licensure for PACE only operators. And then other states, as I think we'll talk about, don't actually have an open door policy for PACE programs at all. They may have a very limited number or run procurement programs for allowing PACE to come in. So the environment varies quite considerably by state as to the basic threshold to get into the program and how to operate.
Thank you, Kevin. Wendy, are there any specific experiences that you could share at the state level, particularly with the way the states may use RFPs?
I don't have specific insight into approaches at the specific states, but we are seeing more states allow PACE organizations and have RFPs out right now or are being lobbied to release them.
How would you find, if the audience wanted to find out about these RFPs, where would they find them?
I think a great resource is the National PACE Association. Organizationally, they have a really good pulse on the universe of offerings and upcoming opportunities.
What would someone do if they wanted to offer a PACE program in a state that currently does not have a CMS partnership?
It's a difficult process, and there's not a single transparent way to do it. But in my experience, a lot of state Medicaid agencies have divided perspectives on PACE. Some folks in potentially some of the budget offices may have an opinion that PACE may cost the same or more than what they pay for just dual eligibles who are eligible for long-term care in their fee-for-service or Medicaid managed long-term care programs. And so they're a little reluctant to authorize it. There's a perception out there that because of PACE's flexibility and benefits, they may enroll people into PACE who otherwise would use fewer or no Medicaid long-term services. And as a result, it costs the state more to have a PACE program. That is an argument that can be had with the budget folks and with the Medicaid offices on a policy basis. And so what I would recommend doing is, if you have a strong policy argument about the need for PACE in a jurisdiction, and based on the way that state currently operates similar models like fully integrated dual eligible special needs plans or Medicaid managed long-term care plans, PACE can fit nicely within a broader menu of dual eligible long-term care options, really approaching the Medicaid leadership at the state and making a case to them that PACE is a really valuable and necessary option. That's really the way that I've seen it work out. It does take a long time for that conversation to evolve. And so it's not something where you can have a conversation and have PACE running later in the year. But you do see states, as Wendy pointed out, more and more states are looking at it as an option because it's so well regarded. Participants and families really love it. And it can save money compared to states that have significant institutional level long-term care expenditures.
Yeah, I just want to add a little note to that. The Medicare program is fully federally funded. The Medicaid program is a federal state share. And then the state side, it comes from the state legislature and the state tax proceeds. And in some states, I have experienced are more welcoming on this issue. But in some states, by the state constitution, they have to balance the budget. And Medicaid can end up being either the number 1, 2, or 3 expenditure coming out of the state. And so you have to sometimes look to see what's the political and financial footprint and legal footprint of a state to see how to articulate your advocacy to the state to show that it's a really good idea. It's not only going to be based on politics, but also financial considerations as well. So Wendy, I know your organization advises traditional MA plans and PACE plans. What would you tell the audience is the significant differences between the two?
Well, besides population, like you talked about, PACE being Medicare and Medicaid, they also have different benefits. But I would say that the variances from a compliance and oversight perspective now are shrinking with the updated audit protocol for the PACE organizations and these proposed rule changes. But in general, like you mentioned in the beginning of this podcast, that PACE covers, the whole Medicare and Medicaid covered benefits, in addition to all medically necessary services, and also includes that long-term care component. Whereas MA is based on Medicare core benefits, but dual eligible special needs plans that are part of Medicare Advantage, the chronic special needs plans, institutional and institutional eligible special needs plans are really closely aligned with the PACE program overall. So, all of it's looking at the benefit package, but it really is a difference between that whole person care that the PACE program provides as their objective.
Thank you, Wendy. Let's move our attention now to the new proposed rule. Remember, February 13th, comments are due. I know it has a lot of information in it about traditional MA plan obligations, but our focus today is on the PACE program pages. If I recall correctly, PACE rules have not been updated for some time. Is that correct, Kevin?
So they've been making incremental updates in the last few years. There was a long stretch of time for more than nearly a decade that they didn't make any significant updates. But last year and the sort of year before, they started making more and more changes. These proposed rules certainly represent another big change in the rules, and in some cases on provisions that haven't been updated for more than a decade.
Great. Helaine, I'm back to you. What are some of the areas in this proposed rule on PACE plans that CMS actually highlighted where they actually specifically needed public comment? Can you highlight some of those?
So CMS definitely asks for comment generally on their proposals with respect to PACE, but there are some specific areas that they talk about. For example, there are questions about vaccination requirements, whether they should require specific vaccinations other than COVID-19 for the members of the organization's staff, of the PACE organization's employees or contractors that have direct participant contact. And they're particularly wondering about commenters' views on the ACIP recommended vaccinations, whether those should be included as the vaccination requirements for the PACE staff with the direct contact, and maybe whether they should use that list with or without modifications. In particular, they asked if they should only require a particular subset of the vaccines, and that subset consists of the flu vaccine, measles, mumps, rubella, the MMR, varicella, tetanus, diphtheria, pertussis, and hepatitis B. So they'd like comments kind of around those variations. Another area that they're asking for comment on is with respect to medical clearance for each member of the PACE organization staff, again, employees or contractors that have direct participant contact. And the question is whether they would be medically cleared of communicable diseases before engaging in direct contact with the participants and on an annual basis. They also say there could be, as an alternative, a PACE organization could opt to do an individual risk assessment, where in that, if they would note or determine that the individual would not need a physical exam in order to be medically cleared, they would be medically cleared without an exam to determine that. Another area that they're asking for comment is with respect to the list of provider specialties with which PACE plans must have agreements. They must demonstrate those. They used to have a list in the regulations of those specialties. It was taken out, and now to address access concerns that they've experienced or see the programs experiencing, they're adding back the list of specialties, but they're asking a comment of whether they should include certain additional specialties. In particular, should they include behavioral health specialties other than psychiatrists? So they will include psychiatrists. They want to know, should they include, for example, psychologists or licensed clinical social workers? Again, these are very much in the weeds of the specific responsibilities of the organization. So again, another area is around the timeline for the PACE organization to arrange for or provide, dispense care. So with respect to arranging for and scheduling the dispensing of medications, the proposal is that should be done within 24 hours after being ordered by a primary care provider. And CMS is saying, should there be a different time frame, or is that an appropriate time frame? They're also proposing a 7 calendar day time frame for the team to arrange or schedule interdisciplinary team ordered care. So again, is that the right time frame or not? Another area is defining IDT, the interdisciplinary care team approved services, with the proposal being it should include services approved by the full team, as well as those approved by individual members of the team. However, it would exclude routine or preventative services. So again, in terms of the proposed 7 calendar day timeframe for arranging, it would exclude routine and preventative, but it would apply to any of the services that are approved by the team. And then lastly, they had asked for input on requiring the appropriate member of the team to review care recommendations from hospitals, emergency departments, and urgent care providers to determine if those are necessary. They're suggesting that be done within 24 hours from a participant's discharge, and are asking for people to comment on the appropriateness of that timeline.
Thank you, Helaine. Wendy, are there a few areas of the proposed rule that you want the public to comment on?
Yeah, I always encourage impacted parties to comment on rules. This is especially important to Helaine's explanation of all the areas where CMS is asking for comment to help promulgate these rules. I'll focus on 2 areas where I think it's important from just, my background that could be important for PACE organizations as they go forward. First, there may be concerns with the past performance indicators, which could significantly impact PACE organizations from expanding if they have not implemented a comprehensive compliance program that includes monitoring and oversight. So they're proposing an evaluation of past performance to review applications submitted. And to do this, they're proposing then types of compliance actions that CMS currently uses for Medicare Advantage plans, so very closely aligning with the Medicare Advantage plans. So that would be notices of noncompliance, warning letters, and corrective action plans. And these are all point-based, and then these points would be used for CMS to determine the application approval status. This could have broad-reaching impacts for these PACE organizations that have parent organizations or multiple sites, because a site could impact the expansion of the parent organization. In addition, I think to the last comment that Helaine explained that CMS is asking for is this proposed rule stipulating the maximum timeframes for the interdisciplinary team to consider the recommendations from that emergency and urgent care providers. This care provision was part of the requirement, I think, that predicated from 2021 audit data in which 75% of audited PACE organizations were cited for failure to review and act on the recommendations from specialists in a manner that met the needs of the participant. I think this is an important component, and CMS is specifically asking for comments, but saying in those comments, if you are going to provide an alternative timeframe, that you need to address how that will ensure the patient's health and safety. Keeping those things in mind, using those guardrails and guidelines for the public to comment.
Thank you for that. Kevin, what do you think would be the outcome of this rulemaking? Do you get a sense of what could be the next step? Will it just come out with answers to some of the issues Helaine did? Do you think it'll be a final rule with comment period? What do you think?
Stepping back from the summaries that Helaine and Wendy provided, it's clear that CMS is now really paying extra close attention to the findings from their audits and wanting to bolster both their, enforcement programs and enforcement rights, but also sort of having a feedback cycle where the clinical workflow expectations about the IDT and the PACE organization's interaction, particularly with specialists, need to improve. And it's clear that CMS cares a lot about delays in access to specialty care and delays in making changes to prescription drugs or therapies that result from interactions with specialists. And I think this rule, as Wendy pointed out, is a proposal. It's CMS trying to find a way of getting the PACE community to improve the way the interdisciplinary care team interacts with specialty providers and make sure that PACE participants who are extremely frail as a class get access to the specialty care that they need quickly, and that the recommendations of those specialists who are not employed by the PACE organization are ingested and incorporated into the comprehensive plan of care quickly. And that's a difficult thing to do. And so I think my expectation, Lynn, is that this will go through a sort of a multi-year cycle where it's finalized, it goes into effect at the beginning of 2024. It's reflected in the audits during 2024, and then it is addressed again in rulemaking likely in 2025 and going forward. This sort of shows that PACE as a policy issue that requires regular oversight by CMS in assessing the quality of care that participants receive is not something that they can just sort of ignore as like a sort of a little cul-de-sac off to the side of the program. It's something that they need to have dedicated attention to that is different than what they do with regards to quality and access in other managed care programs. The IDT and this whole care planning process is PACE specific. There's nothing like it in the model, even the model of care requirements for special needs plans and Medicare Advantage. For me, this rule indicates that they have invested the time and energy in figuring out where the problems are in actual access to care, and that they are going to really start changing the fundamental structure of the way they regulate the way PACE plans interact with specialists. And so I think that's the real challenge of this rule for the industry. And it's clear that CMS means business about it because of the enforcement and past performance rules that Wendy and Helaine were talking about.
And I know our audience might have said, oh my goodness, they're so micromanaging how the work has to get done. But I will tell you, part of why CMS is getting into those micro levels is because then when they do the audit, they can show this is what the reg required, and did you do it? And it becomes more specific so that the auditors themselves have more specific guidelines of exactly what to check off the box. Did it happen or not? Did the entire team sign off or not? Are you able to use psychologists and get access? I'm sure on the mental health side, that's a big issue. Let's get, time is running out for us. So I'm going to give each guest a question with, let's give it a quick answer. Okay. Helaine, the proposed rule, is this going to be problematic for PACE plans? What do you think?
So Lynn, as you were just saying, I think not only is this going to be helpful for auditors, I think in a lot of ways it's going to be helpful for the PACE plans themselves, because it's laying out these requirements much more specifically so that they know what they have to do. It's not leaving these open for their interpretation. And then, the auditors comes along and says, well, no, that wasn't a prompt response. You needed to do it an hour quicker or something along those lines. So I think in a lot of ways, this is maybe welcome by a lot of PACE plans.
And Wendy, just a quick question and answer. Can you give an example of something that PACE plans may really appreciate?
Certainly, Lynn. If I was a PACE organization, I would appreciate the rule modifications around the timing of the audits and alignment to a calendar year. This is consistent with Medicare Advantage, and it will help the organizations alleviate the timing issues around their audits and performance.
And Kevin, when do you think the regs will be final?
Well, it's always treacherous to predict when CMS will finalize regs, but from if past is prologue, I think we can likely expect it to be sometime in May that we would see a final rule with an effective date of January of 2024.
Very good. I want to thank our panelists today, thank them for sharing their experience and knowledge here. I also want to thank our listeners for attending. I'm your host, Lynn Shapiro Snyder. If you like what you heard today, please remember to subscribe to our podcast series, Diagnosing Health Care. It's available where you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.